Hello and welcome to Ask Dr. Mingle, a Q&A series from Mingle Health where we answer your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good morning, or whatever it is, to all of you tuning in. I'm Dr. Dan Mingle, here to answer your questions, at least to the best of my ability.
Before we get started, I want to invite our listeners to send us their questions for Dr. Mingle. You can leave your questions in a comment on LinkedIn or on YouTube, or you can email them directly to us at hello@minglehealth.com. Okay, let's jump into today's questions. Our first question today for Dr. Mingle is from Heather, and Heather asks, how do you know if you're a small practice, and what changes if you are?
Great question, Heather. Medicare defines a small practice as a practice with 15 or fewer billing professionals. It can be a moving target with providers coming and going through the year for billing dynamics. Uh, and we can make our best guess of what size you are. Some it's quite clear, so sometimes it's not. But ultimately, the Medicare is the final arbiter of what size you are. And you can get a clue as to what their current determination is by looking at qpp.cms.gov, the QPP Quality Payment Program website. There's a place to put in your NPI, your National Provider Identifier, or at least one from the practice. And once you get into that, there's a way to expand to look at your whole group. And a group is defined, as you may recall, by tax ID number. So it's the 15 or fewer providers sharing that same tax ID number to do their billing and collect the fees. And Medicare keeps track of your size both through the data that's in PICOS and on the billing dynamics for the year in question. So you can, when you access your data at that site, it'll tell you whether you're considered as part of a small practice or not. It's an important status to recognize. I think you don't necessarily want to act as if you're small, but understand most of the benefits of being a small practice accrue to you in Medicare's calculations. So it changes what you expect is the outcome from the year's activity. One thing they do is automatically reweigh promoting interoperability category to zero, distributing the standard weighting for a small practice is 40% quality, 30% cost, 30% improvement. They also give a slightly different redistribution policy framework. So when you drop out of when you have a reason not to, an excused reason not to submit another category, the scores distribute a little bit differently. Small practices are still permitted to use the claims submission technique, closed to all larger practices. But beware, claims is still one of the least reliable ways to submit quality data to Medicare. There's lots of potential failure points, and it's not necessarily a benefit to be able to use that. But for if it's working well for you, if there's measures that work for you there, it's you can do a very good job with claims. And one interesting thing about claims is that if you do find that there's or suspect a failure, by engaging us toward the end of the year or early in the submission season, we can repackage your claim submission as a registry submission, assuming that the measures are usable both in claims and registry, which usually is the case. Small practices also still get a small practice bonus, which is 6 points added to the quality score, no matter what that score is. And for the time being, small practices continue to enjoy a 3-point floor on class 2 and 3 measures, which means that if you submit a measure with fewer than the case minimum, or fewer measures, the case minimum is 20 patients reported on. Or if you submit a measure without the minimum data standards, which this year is 70%, you still get 3 points for that measure. Still extending that to larger groups, but after this year, when that disappears, you'll still enjoy that as a small practice.
Great. Thank you for the question, Heather, and we hope that helps. Our next question today is from Cindy, and Cindy asks, do you have any advice for specialty practices in MIPS? We don't have enough measures, we don't use an EMR, and we are non-patient facing.
Cindy, great question. A lot of my specialty practices struggle with just those issues. Uh, let's There's a little bit of complexity in that question. Let's break it down piece by piece. One measure, not enough measures. One measure may be enough, and there's a couple ways that can work for you. First, there's a set of rules attached to this program called eligible measure applicability, or EMA. And this, to Medicare, your submission of one measure suggests to them that you should be able to submit others. And they put these expectations into that set of rules called eligible measure applicability. If that only indicates that there's no other measures you should be able to submit, then that's one piece of evidence that they may let you get by with a single measure submission. Despite what the EMA, the eligibility measure applicability rules say, there may not be multiple measures that you can submit. And in those cases, you end up having to create a hardship exception. Make application, and applications are typically open early in the year. I think they're open now for hardship applications for 2022. Make an application, explain your case, and Medicare can either waive your need for multiple measures or redistribute your points so you don't have to make a quality submission. The next aspect is not using an EMR. And we have made a business out of finding ways for anyone to submit, no matter what their circumstances. For registry measures, what Medicare is now calling the CQMs, or clinical quality measures, sometimes the MIPS clinical quality measures. We can help you select those measures you want to do and help you build an Excel spreadsheet or another submission mechanism, data submission mechanism, to help you build a submission based on chart abstraction. Of course, the part of the search for applicable measures is to look for those with smaller denominators, so you don't have to pull as many charts to abstract. And sometimes data is accessible from other sources, like we can build for some measures, we may be able to build a submission for you from your claims data, which for most people is accessible using the files that they send to their claims clearinghouse. In the case of some oncology practices, we help build measures from the tumor board, the tumor management databases that they maintain. So any database containing potential numerator level data for a measure is fair game to build from a registry. And also, we can blend those measures to get your numerators. We almost always get the denominators from claims data, and most everyone has access to claims data, and then find ways to build the numerator from one or more sources. And finally, being non-patient facing, that does make things harder in some ways. It means you're automatically accepted from promoting interoperability. Although if you make a submission for promoting interoperability, they will score it, but it doesn't necessarily mean anything for the quality measures. And what I've noticed is that pattern, that there are fewer measures, fewer choices of measures for those people that are on those providers who are non-patient facing. But again, it gets you back to that same list I provided earlier. Look for those few measures. If you're limited to one, make limited to a small number of measures. Check to see if you're still scorable based on the EMA criteria, and make an application for exception if you can't. Now, we can be of help, and this may be a great reason, even if you don't expect to make a submission, we can help you build that case for not needing one. We apply our measure applicability testing, what we call our measure analyzer, to look at your claims data and see what patients' diagnoses, services you've provided that make you eligible for certain measures. And by doing that measurement, by saying I have no eligible patients for such and such a measure, we can help build the case that you don't have measures available. Now, just because you have those eligible patients based on the codes doesn't mean that you can do the measure. If I'm a surgeon, see a patient with diabetes with a visit code, an office visit code applicable to that, and because I consider diabetes in my advice, I diagnose diabetes. That doesn't mean I'm taking care of hemoglobin A1C, although by the specs, it looks like you have eligible patients. So that measure analyzer just as a first pass, then we have to make a logical analysis of, well, what actually do you do, and explain to Medicare why the this count of eligible patients doesn't mean that you have the numerator data to go along with it. So can be complex, but it's not hopeless if you're in the circumstances that Cindy describes.
Yeah, it's a great question, Cindy. And I know we hear it pretty often that MIPS is tough, and it's especially tough for specialty practices. So hopefully that helps. Our last question today for Dr. Mingle is from Katie. And Katie asks, as we go through MIPS in 2022, what do you think is most important to focus on?
Oh, thanks, Katie. Great question. 2022 is an interesting year. It's kind of the last year of transition from the ease in rules of the first phase of MIPS. It's likely, of course, I can't really put a guarantee on anything, but it's likely to be the end of a long string of automatic exceptions because of COVID. Uh, and promises to be the hardest year yet. And it's also the start of a new set of programs to take us into what's the next version of MIPS that's projected to be in full force in the region of 2025 or thereabouts. So an interesting year. I'm hard placed to say that there's one thing that's most important to focus on. But if I did have to choose one, I'd say it's cost. Um, uh, Cost is something that's been gradually building up. It started with cost getting 0 weighting and quality getting 60 points in standard submissions or in the standard scoring, and gradually brought them down to the point where they're now neck and neck, 30 points for each. However, COVID created a situation where cost was forgiven for a couple of years. And it also, whatever cost has been assessed on you, those things never show up in your adjustments until 2 years after the performance year. So we really haven't felt cost much, and you could feel it big this year. And unlike quality, you can see in various looks in your records, you can sense from the patient flow and your methods of providing care. How A rough idea, and you can get fairly specific idea of how well you're performing in quality. But cost depends so much on things that happen outside of the practice that it's much harder to get a handle on that, and the data is not so accessible. So as you think about cost, you want to start looking back at clues. The old QRUR reports that came in the PQRS system and value-based modifier is one place to see how you've performed historically. I wish they had, through these years of COVID, continued to provide cost analyses, even though they weren't included in the scoring. But you may find in some of the feedback reports you've seen since the beginning of MIPS, some feedback on your cost performance. But then you need to rely on some common sense things to how to contain costs. So that would be my if there's one thing to focus on, because it's so new, look at that. But at the same time, you don't want to lose out on the other tried and trues. For quality, make sure that the quality measures you're going to depend on are still valid. Their specs haven't changed. They're not topped out. They're benchmarked. That data is available on qpp.cms.gov. Even if you performed well last year against the benchmarks have changed, and you may not be performing so well this year. So again, keep up with the benchmarks. I always suggest that people work on new measures. You should have some that you're not expecting to score well, but you're getting some practice with it. You're learning how to record, to document the numerator data better, so that when one of your measures disappears for any reason, you have others to substitute in there. Regarding promoting interoperability, it's important to keep up with current standards. Make sure that you're in the right certification, EHR. Every year, Medicare changes the requirements a little bit, or the options a little bit, for interoperability, for sending data, for receiving data, for sharing data with patients. Pharmaceuticals, that e-prescribing has been relatively stable, but keep an eye on those things that are changing. And of course, some of there's a couple of things that aren't difficult to do, but are really pass-fail kinds of dynamics. So make sure you've done your security analysis. And of course, this year you have to tell them whether you've read or not read the Chief Safer Guide. So be sure you keep up with the basics there. Not much, of course, specs change and improvement activities. So make sure whatever you're relying on for improvement activities is still supported. The specs haven't changed, and you're keeping up with the requirements to prove that you've been participating.
Yeah, great question, Katie. I was going to add that if you go to minglehealth.com, in our resource center, we have past webinars on cost, and we recently did a webinar on MIPS in 2022, and it's a great place to start. So be sure to check that out. Okay, Heather, Cindy, Katie, thank you for your questions today. We appreciate them and we hope we've helped. If you have a question for Dr. Mingle, you can send it to us. You can send it to us in the email at hello@minglehealth.com, or you can leave it in a LinkedIn or YouTube comment, and Dr. Mingle will pick a few of his favorites to answer each episode. Thank you, Dr. Mingle, for sharing your insight with us today.
Thank you. And thanks for the great questions. I look forward to your more further questions and comments. Don't hesitate to correct or supplement my answers. We can be smarter together.
All right. Thanks, everyone. See you next time on Ask Dr. Mingle.